Welcome to the webinar, Conventional versus Digitally Guided Full Arch Rehabilitation. This lecture is being presented by Jeff Carlson, CDT, and we're going to begin shortly. And now it is my distinct pleasure to introduce Jeff Carlson, CDT, NDX's Senior Implant Specialist. Jeff has more than 40 years of dental experience with almost 30 years focused on dental implants. That means he started when he was like 15. Jeff is the primary author of a 300-page, fully illustrated cookbook created for restorative dentists, and he is co-author of a corresponding auxiliary manual. Jeff co-developed a restorative-based training program that more than 9,000 dental professionals have attended nationally and internationally. As a senior implant specialist for NDX and Sequence, Jeff provides technical chairside support and lectures across the country on immediate loading, full arch restorations, and sequence-guided prosthetics, and the latest advancements in implant technology. And now I get to say, take it away, Jeff.
Thank you. That's all we have time for tonight. Hello, everyone. Thank you so much for taking time to join Jessica and I this evening. I'm very excited. I'm going to be sharing some brand new technologies I've never shared before. I hope some of you are some repeat people. And this is, our profession is always going through changes and, advancements. And sometimes it's very difficult to keep up on, what's new. And then also things that are new, are they really working? Is it all just a marketing, kind of a promotional, or is it actually clinically significant and can it benefit you and your patients? So I wanted to really take a look tonight about when we come to full arch reconstruction. And, many of you have probably worked with the conventional workflows, and some of you have been avoiding them or are newer to dentistry and haven't, and that's kind of been left behind to a degree, but still a lot of people are doing it. There's nothing wrong with it by any means. It just depends on what you're comfortable with. So I'm going to share some. We're only have basically 50 minutes tonight, and I'm going to hit some high points. And you'll get my contact information at the end as well. You can reach out to me for more information. We do have a lot more on our educational website that you can review that goes more in depth on some of the information I'm talking about tonight. What we've seen really happen, quite honestly, is that pretty much all the major implant manufacturers have got on board with full arch. They have their own names to it. Some of them have, are making their own guides, do planning for you, design. So a lot of the implant companies have, this is not just new, but they've really stepped up. And so there's a lot of technologies out there, protocols, workflows. It can be very confusing. So my goal tonight really is to really help you with some of the decisions that you're going to have to make when you're looking at a full arch reconstruction or a full mouth reconstruction with your patients. So we're going to talk about surgery tonight, and we're going to talk about restorative, because you have to make decisions in both areas. And there's a lot more options now than there's more than we've ever had. And so we're going to start talking about the surgery. We're going to talk about freehand surgery, guided surgery, and then there's full guided surgery, and then photogrammetry. That's really become pretty popular. And then precision IOS, precision intraoral scanning, has really become a game changer when it especially comes to the restorative end, but also for our surgeon friends, whether you're the clinician that's doing the surgery and the restorative, or if you're a specialist and you're working with a restorative base, you're going to see tonight how the precision IOS has really, really changed some things. So let's get right into it. So we're going to start, of course, talking about surgery. And what I wanted to start with is just a quick look at freehand surgery. And so with freehand surgery, it can have something, with a lab, without a lab or in-office fabricated surgical guide, possibly, as you see A here, a guide just to show the position of the new prosthesis, where the teeth are going to go. This could be very helpful for a couple of things. Here, what you see is a trough. Basically, that is a a clear denture, for lack of a better term, with a trough cut out of it. Palatal's full, so it gives you a stopping position. But what it does for the surgeon, it lets them know, it says, look, here's where the teeth are going to go. And then you're free to go wherever you want in the alveolar bone, but just know we're putting teeth here. So that helps with your implant positioning. But if you're placing the multi-unit abutments, it's very important so that you know whether or not is a 17-degree angled multi-unit going to be sufficient, or need a 30-degree, or can you get by with a straight? So that's a minimal. If you're even doing free-handed, I would strongly recommend you at least do what we call a trough denture. Otherwise, people are just using maybe some type of parallel pins. To the far right is just leaving a tooth there as the long axis of a tooth to give you some type of a reference for parallelism. So free-handed, again, I'm not going to teach people how to do these things. I am a dental technician, been in thousands of procedures, surgical procedures, but I just want to bring out some highlights of some options that you have. So when we talk about guided surgery, this has kind of changed a little bit from what guided really means. I'm going to talk about guided, and then I'm going to talk about fully guided next. So really what guided means is that you're going to use some type of fabricated, this could be an in-office. Many of you now have in-office printers. You've got the software. You can do your own, design your own surgical guides, print them in office. That's perfectly fine. What you're looking at with guided surgery is that it's going to do really two things for you. It's going to control the depth of the implant and the rotational position of the implant, in addition to of course, the position of the implant, mesial-distal, buccolingual, buccopalatally. So that's really, and that those are nice to have, especially when you have a narrow bone that you're working with. You have to be really precise. Sometimes, no matter how good you are free-handed, it gets very challenging when you have different variations of density of bone. You're trying to freehand, and you go from soft bone to dense bone, and then your drill maybe gets kicked a little bit one way or another. So having guided surgery is a good thing to do still, just to ensure when you're in maybe the more challenging type of cases. The one on the left is one that's designed where if you wanted to literally do a flapless surgery, you could do something like that, where it fits just right directly onto an edentulous mucosa, and tissue punch and place your implants through that. Most commonly, surgical guides, as you see in the middle, where they're going to have some teeth that help to adjust, or I should say attach to, and then place some implants, remove it, and then continue on with the rest of the implants. Most surgical guides, as you see on the far right, there'll be some reference point to help you with that timing of the rotational position. This happens to be an implant carrier, or placement, I should say a placement mount that has a hex to it. And to line up the hex properly, you would center the flat of that hex with one of the lines with this particular type of a guide. So that's what guided surgery is giving you, is depth control and rotational, also referred to as timing of your implants. So since we're talking about conventional prosthetic conversion on the day of surgery, this is where this is what we've been, this is what we did initially, 20 plus years ago, and still being done today. It is time consuming. It's more challenging. There's more variables that can come into play, and there's a little more arbitrary decisions that are made. Basically, what you see, the lab is going to get that inner arch space that we're all looking for the prosthesis. And the guideline that we're really targeting for is to have 15 millimeters, which is from the top of the implant platform, which very often is going to be at the crest of the alveolar ridge after bone reduction. So you're looking from the top of the implant, platform of the implant, to the occlusal plane. Ideally, if you get 15 millimeters, that pretty much leaves a door open for you, for your restorative doctor, to select any type of a prosthesis. Now, we know that zirconia restorations, you don't need as much inner arch space as you would, say, for the denture teeth and acrylic with a titanium bar, let's say, or even maybe the nano ceramics. But if by going with 15 millimeters, it gives you the ability to a wide variety of prosthetic options. When you start having less than that of inner arch space, then you start limiting the type of restoration you're going to be able to provide for the patient. So the lab is going to basically do the arbitrary bone cut. They'll do immediate dentures. Then whether you're doing freehand or guided surgery, then you're placing the implants, placing your multi-unit abutments. Then the next step is going to be, okay, with this immediate denture, you have to create the holes where we can, these temporary copings, as you see on the far right, bottom right, that they're going to protrude through the denture in a proper position. And you get to use a rubber dam. Those are always fun to do on a full arch. So, and I'm not going to show you how to do it. I'm just giving you an idea. These are little steps involved for doing it. So then once you do pick up the copings, as you see here in the top left, the metal copings have been luted to that immediate denture. And then you cut the palate out, you cut the borders back, polish it. And ideally, after hopefully, an hour, maybe 2 hours, you take that immediate denture and you convert it into what we'd refer to as a hybrid screw retained provisional. And here it's seated, and then you plug the screw access holes, and that would be your, your conversion. So when it comes to doing these freehand conversions, I just showed you the last couple of slides. Most clinicians are going to have a chairside technician. So not every technician is capable of doing this. It takes special training to do that. So you're looking at the technician's availability, and most laboratories will charge a fee for that. And it does require more time, quite a bit, significantly more time. So based on how you're set up with your operatories, if you have a place for a patient to be where you can still have some, if the surgeon, if it's in the surgical practice, they can move the patient to another room, then the technician can be working there with the restorative doctor. Or otherwise, if not, you have a chair that's being tied up until they finish the conversion process. You definitely need to have more parts and pieces to do this, because the multi-unit abutments, you have different cuff heights, you have different angles. So you want to have enough inventory when the time comes for these surgeries. And then quite honestly, our printed provisionals these days with the materials that we're using are stronger. They're monolithic, and they're stronger than conventional denture. Now, many of the labs are printing these immediate dentures, and that's an improvement as well. But still, sometimes when you're cutting back arbitrarily, you can get the denture can become pretty thin, and your hybrid can be fairly thin. So something just to keep in mind. So when we talk about fully guided now, what changes with fully guided, you're going to have guided bone reduction. You're also, again, you're going to have a guided the osteotomy, so you get your depth and timing controlled. The implant placement guided. The multi-unit abutment placement also, with most of the guided systems, they have some type of a way to indicate the correct position that screw access, especially very importantly, on an angled abutment, angled MUA abutment, to get it in a proper alignment. And then the conversion or the pickup of the provisional on that day of surgery is also guided. So many of you have heard of stackable guides. That's kind of what we're talking about here when you get into the fully guided. As you see in the bottom photo there, we're actually picking that up, and I'll show you some more photos of that. So with fully guided, you're going to have, everything will be customized for that patient, the guides, surgical guides, prosthetic guides, the prosthetic components based on what implant laboratory you're working with. And some implant companies are providing this. The prosthetic components may be customized or may not be customized. What I mean by that is the temporary copings often need to be cut. The heights need to be cut for each implant site. So when you do what I refer to as a fully guided that we provide, you're going to have those temporary copings already pre-cut and pre-made blockout plugs for that. And based on what option you choose with a fully guided, you will either get one long-term provisional or two long-term provisionals. And I'll talk real briefly about the advantage of having two long-term provisionals. So then after you've had your your online meeting, you've submitted all your records in, your CT scans, IOS scans, et cetera, photos, the prescription. Then the laboratory will design your case. This is a case here for the sequence case that is boxed, comes in a box, everything's labeled, organized, shipped exactly in this box to you. And what you're actually going to have there is in the fully guided in sequence protocol, and with some of the other companies, not everyone does it the same way. A lot of labs don't have as many of these components in the guides that I'm sharing with you here. It is kind of complex procedures to do all these models. These models actually have magnets on the base based on the articulator that you indicate. We can actually customize, you can actually have it mounted on the articulator and check everything out in your office prior to surgery. But you're getting your guides, as you see there on the bottom left, there's what we call bone foundation guide. That's a key part for these stackable guides. You also will be receiving then your surgical guides. For prosthetic guided, you have a rotation guide. It helps you guide the multi-unit abutments, tissue gaskets, and then the provisionals. And now based on who you're working with, the components would be ordered from the manufacturer. These are going to be additional costs for the components, but they would be customized, meaning that the parts would be shipped to the laboratory. They would customize the heights of those abutments, so you don't have to do that the day of surgery. You also get a very comprehensive series of reports, photos of your case at different stages, bone density charts of each implant site, drill sequence, a lot of information to help you. So if you're new to the full arch, really strongly recommend that you go with a fully guided system the first couple of cases, then branch off from there. But this will really help to keep you on track. So just kind of give you an idea, this is a short little video. So this metal piece is what we call a bone foundation guide, and the plastic piece is a monostrut that's pinned to it. This plastic piece is how you orient it. The key is you have to get this metal framework positioned exactly in the proper position. And to do that, we're utilizing a couple of teeth to maintain that position. And then also there's a strut in the middle I'm pointing to right there that also will touch right onto the alveolar bone. And so with this, then you'll see these protruding cylinders, lips kind of covering it here. But here you would take a 1.5 20 millimeter drill and do a horizontal osteotomies from the buccal plate, buccal cortical bone through to the palatal or lingual bone. And then there's a anchor pin that would engage both buccal and palatal or lingual bone to stabilize that. And there'll be 3 of these horizontal pins there. Then you simply remove these little small pins, remove the plastic, and then you're on your way to the rest of the procedure, which is going to be, here we're just showing there's a model showing the bone cut to make sure that that's how much. This case had a lot of bone reduction needed for this particular case. The average case with dentition usually need about 3 to 5 millimeters alveolar reduction to be able to have that 15 millimeters of interarch space. So just know that often you will have to do some alveoloplasty for the final prosthesis. So with these type of guides, you go from the flat of the metal here in the buccal. You can't really see it, but there's a flat also on the palatal side here, and just reduce the bone straight across. The surgical guide gets pinned onto that the same way you saw the other plastic guide. And then you do your osteotomies, and then you get your guided surgery, your timing, and your depth with that. So then with the fully guided system, you're also going to have the guided prosthetics. So the temporary copings would all be seated onto the multi-unit abutments. The tissue gasket was pre-made. Then the provisional itself, this is your stackable guides, okay? So that it's like a stackable provisional, has these arms on it, and then they'll get pinned onto that framework just like you saw the surgical guide and the monostrut. So now what we're going to do, when it's pinned in place or blackout plugs are in place, so patients open, there's no trying to orientate the provisional into the right position. If you got the metal framework right, it's in the right position. So now we have pre-drilled injection holes out on the buccal for each implant site. So we're injecting through those holes and you're filling up these sites here. Once it sets up, you remove the little prosthetic screws and you remove your prosthesis, and your conversion, if you will, is really nothing more than backfilling the little voids here, removing the arms, and maybe some minor polishing, maybe a 15 to 20-minute finishing job on that, as opposed to what I showed you earlier on, or cutting out palate, trimming borders, backfilling more the integral side, etc. So there's ways that some of our protocol, you have the option of one provisional. Another protocol is you get a second provisional. That second provisional, you'll pick that up at the same day of the surgery. So you do the first one, remove it, place the second set of copings on, and repeat what I just showed you in the last couple of slides. And what this is going to give you now is two finished provisionals. This one can actually be as a backup, but when you go for the restorative doctor or for the restorative process, then you really minimize a lot of your appointments versus multiple appointments when you do more the conventional way. Okay, so now we're getting the fun stuff here. So let's talk a little bit about where we're at now. And I put this, did you know, because I'm finding when I talk to clinicians, a lot of them really don't understand that what photogrammetry does or doesn't do. And photogrammetry has really been a nice adjunct to this type of protocol for sure. Very, very precise accuracy with the scans they're talking between 5 to 10 microns, which that's insane. I mean, not insane, but that's very tolerances, accuracies like that, fit like that. We've not had that all the years we've been doing dentistry, really. So photogrammetry uses special scanning, your scanning unit, the photogrammetry unit itself, and then scanning indicators that the different companies have that provides a 3D registration of only, now this is the key part here, it's only recording the implant position and the multi-unit abutment position, which we refer to as we shorten it up to MUA, multi-unit abutment, because when you do these scans, the multi-unit abutment is on the implant. So we're not really scanning the implant itself, the top of the implant. What you're doing is you're scanning the top, you're scanning a scanning body that's screwed onto the multi-unit abutment. So I'm going to show all that coming up here. But what's very important for you to note is that it does not capture the required data that the laboratory needs to do a provisional for you. It doesn't capture the working arch dentition or the tissue of the working arch. You still have to do a scan to get the opposing arch, the dentition of the opposing arch, and also an IOS scan, intraoral scan, to capture the bite. So you have to get that data through IOS or intraoral scans. So photogrammetry has to be joined with an intraoral scan. Now, there's a couple units, I'm only really aware of one out there that will also pick up some of this information for you on the day of surgery. But we'll talk a little bit more about that coming up. So prior to surgery, this is very important. This is pretty much true with any of the labs that are trying to meet your desire, your need to have either a next day lab fabricated provisional, next day meaning the day after surgery. So that would mean the patient would leave with just multi-unit abutments placed with healing caps on top of them, no teeth. They would leave that day of surgery, but the next day you could receive via FedEx, UPS, or maybe you have a local lab doing it, you would receive the finished provisional. Or you could get a same day design. Now, this is important, a design. So if you do have your in-office printer, so the laboratory could design a case. We're targeting to try to do within the 90 minutes to send you a design after you submit the files from us on the day of surgery. But you need to have preliminary scans at least 2 weeks. I mean, there's at 1 week, it won't happen. It's got to be about, a week, 2 weeks, 10 days or so ahead of time. The preliminary scans, iOS scans, which you would send into the laboratory, the working arch as it exists, the opposing arch, and a scan of the bite. So you need those 3 scans. Now, if you're changing the patient's vertical dimension of occlusion, their VDO, what you're going to need to do, the best way to do this for most accuracy, to minimize some of your bite adjustments, who's ever delivering that provisional to the patient, or especially if you're going to print it in your office and deliver it yet that afternoon, you don't want to spend a lot of time adjusting on bites. So if you are changing a patient's vertical, and you're using an appliance to open the vertical, scan that patient's bite with that appliance in place so that we know that VDO. So from the initial scans, the laboratory then can design your occlusion, the setup and everything. So it should be quite accurate for you when you go to deliver that provisional, whether it's lab fabricated or you print it in your office. So again, we're still talking about photogrammetry. So this is just kind of show you some of the ones that are, there's more than this. There's been quite a few of them nowadays, and some are blending their iOS in with photogrammetry. The iMetric, iCam is one that's very popular. PIC system been around quite a few years now. Very proven. All these are very proven systems. The Micron Mapper. So I'm not going into much depth on any particular one, but I have to show you something. So I just have a couple of slides I'm going to show you utilizing the Micron Mapper. And we're just saying that, quite honestly, it's pretty similar what you're doing, but there are nuances, of course, with each system, the different settings. Some you have to do a little calibration, but they all are good systems. So here you're seeing what you see on the right. Implants have been placed, multi-units have been placed. These are the scan bodies. They're like little, not as much as a domino, but you see the dots on them. You're going to find with each system, you'll have certain ways you need to try to position these so that the camera picks those up. And so you do your first scan, that's going to capture the implant position via the multi-unit abutment and actually via the scan bodies. So when the laboratory gets that scan, they already have those other scans, so they know where the teeth go in each arch and how the bite is. So the data they're waiting to get from you is they're waiting to get the implant position data and the tissue data. So we're coming up to that next here. What you're actually, so here we're scanning, and then in real time, what's happening on your laptop just off to the side of the patient is as you're scanning, the image of these scan bodies pops up on the screen. And based on your system you're using, some turn different colors, some beep at you, some do both. But you're going to know when your scan's complete. And what's really crazy is some of these scans are like 10 seconds. Others are a little bit longer. But when we talk about longer, we're talking about like a minute and a half. So it's not like taking impressions that we used to do, open tray impressions and those crazy things, the way we had to do it and the way some people are still doing it, quite frankly. So this is just kind of showing you what's happening in kind of real time. Then you would submit that data to the laboratory. And then when it comes to what I'm referring to, we kind of coined a phrase, precision iOS. Another terminology out there that you may hear is gammetry. So you have photogrammetry and then gammetry, which is the protocol where it is the same. It's just terminology is a little bit different. Some are trademark terminologies, et cetera. So we're going to use the phrase precision iOS, and throwing the word precision in is referring to the fact that you have some type of these are not just individual scan bodies that you would use for a multi-unit crown and bridge case or a single implant case, just to scan that, send it to lab, and they make you an individual crown. Those scan bodies are not sufficient to do full arch. You really need to have the accuracy. You really do need to have these type of scan bodies. and the accuracy in the scanning with these scan bodies, they're being reported at upwards to around the 50 to 75 microns or so. So once again, very accurate. So here you're seeing 3 different examples of them, and there's more than this as well, by the way. These are ones that are pretty popular that we work a lot with. And you can see the names also: scan body, scan jig, scan flags. You just have to, when you pick your system, you're going to have your terminology, and that's what you're going to work with. Your labs that are doing this type of technology, they're versed in all the terminology as well. But just as a reminder, you're going to need one of these systems in conjunction with your photogrammetry. So the best thing I can say to you, if you're kind of new to this, talk to your laboratory. Find a laboratory that can support you with this. Find out what's their protocol. Some labs have different ways of doing it. So whoever you're working with, just follow their protocol. They've worked it out already for you. So that's the good news. You just need to communicate with the lab. Level of communication is extremely high in these type of cases. So here we are now. We're at the day of surgery. We're going to do the precision iOS scanning. And so the first thing that's going to happen for the day of surgery would be to place what's called fiducial markers or reference screws. Really interchangeable terminology. So you may catch me saying reference screws or fiducial markers, but we're looking to have, for an upper arch, we like to see 2 in the palate area, where it just makes sure it doesn't interfere with any of the surgical procedures or prosthetic procedures. For mandibular arch, we like to see 2 as well in the retromolar pad area. We talk about a 3rd reference screw. It just gives another point of reference for the laboratory. Labs are working in a 3-dimensional world, but they're viewing it at a 2-dimensional because it still is on a flat screen. So if you really want to be precise, that 3rd reference screw really helps to minimize, if not eliminate, variables in the alignment of the scans. The labs have, if you could see a screen with all these scans, these technicians that are doing this are, to me, they're very skilled, very amazing to me, how they know how to work all this digital technology. But you need to have these placed prior to the surgery before any incisions are made. And then you do your initial scan with that. You're scanning all of the anatomy, capturing these markers. You're getting everything in here, kind of like you're scanning for a denture, almost a digital denture. But you want to make sure you get that. So that's your first scan. You're going to scan the opposing arch. Again, we're on day of surgery. You're going to scan the bite. Then you're going to go ahead, and now you're going to go and start your surgical procedure. Reflect your flap. Then you place your implants, whether you're doing free-handed or guided. That's really up to you. And you're going to also place the multi-unit abutments. Okay. So now for these precision iOS scanning bodies, what you're looking at here, this is for when you want a next day provisional. This is what you would be doing. You'd already sent those preliminary scans a couple weeks ahead of time. So now MUAs are placed. You would place these scan bodies directly onto the multi-unit abutment. And based on the system you're working with, this happens to be the OptiSplint system that we're showing here, that with their system, that they like to have you, you're going to point these, the lingual, if you will, the palatal portions out toward each other to the center of the arch. Again, here's your little fiduciary marker here. What is the critical part when you're scanning now? This is what's the part of this particular system. What you're scanning is this portion of it. The geometry is there that the scanner is going to pick up, and that has all the data that the software is going to need to have. So when you're scanning, that's what you're focusing on, is capturing this area. Then on your fiducial markers or your reference screws, I got a little guy tucked way back here. I highlighted my little yellow circle here. So you want to capture all of that in your scan. So all we're looking for here are those areas. We're not worried with this scan. We're not worried about the tissues. We're worried about the physical markers, if you will. Okay, so Now we've got that scan. You remove those scan bodies. Then you're going to place your healing caps on the multi-unit abutments, suture around that. And there's a lot of different types of multi-unit abutments. The configurations. Some implant companies, they're different between each other. Some have their own different, within their own system, they have different designs of them. So just talk with your implant manufacturer, talk to your implant rep. These people are pretty knowledgeable, most of them are quite knowledgeable. They can help you with this. But what you're seeing here is now you've sutured around those multi-unit abutments, around the healing caps. We still have our fiduciary markers are still in place here. And so now you've sutured. What we like to see, and again, labs may do it differently, but we'd like to see you now remove those healing abutments and then take your iOS and scan the tissue, scan the top of the multi-unit abutments, the exposed multi-unit abutments, scan that. So this is what the scan looks like here on the right. So we want that scan. So now we have a scan of the tissue. We have a scan of the multi-unit abutments. So when the lab has this in their computer and they're lining it up, they have a lot of things that they're lining reference points to really make sure they get this accurate. Some company, so based on some systems, they may have special healing caps that are both a combination of a scanning abutment as well as a healing abutment for suturing around it. So just again, based upon your system. At that point, you're done, your surgery's done, you can dismiss your patient. Then you would submit or upload all that information to the laboratory. Again, reach out to the lab, find out, how do I get on, how do I hook up, connect to you? Do all this ahead of time. Don't wait till the day of surgery to start calling up the lab and say, okay, what's your address, or how do I submit my scans? The provisional then that you would get the next day, the printed provisional the next day from the lab could be the second day if you missed the cutoff time. What I mean by that is, most labs are going to need you to finish your surgery to be able to give you a provisional, either the design for you to print or for you to receive a fabricated lab one the next day. You need to have your surgeries done usually by about noon. And based on your time zone, based on your lab's time zone, by noon, submit all those files so that the lab has time now to do all that alignment of the scans. Then they got to print it, stain and glaze it, get it to FedEx or UPS that same day, so that the restorative doctor or whoever's going to place the provisional gets it the next morning. These will not have metal copings in them. You'll use, and by the way, you got to talk to your laboratory about the screws, the prosthetic screws for this. They're not going to typically be your standard prosthetic screws. They may be something that's called a desk screw, a Powerball screw, Rosen screws, a lot of screws that you, again, talk to your labs ahead of time. Don't dive into this out without having a good lab partner to help hold your hand through this. But I'll tell you what, it's amazing how the occlusion is so spot on these cases. It's really terrific. All right, let's jump into the restorative portion of it now. So we're going to talk about analog, conventional, fully guided, and precision. So when it comes to the analog, this is really just a slide showing when now the implants have integrated, you're ready to go to the final prosthesis. Not everyone's going to do a custom impression tray, granted, but there are a lot of appointments that are needed here, and there's usually a couple of weeks between the appointments. You've got the lab's time to do that. You got shipping time, etc. So again, this is the conventional way. Some people call it old school. Fully guided. Now, this is showing you that second provisional that was picked up. What that second provisional would do, because that second provisional is acting as your verification jig. It's acting as your white block, your try-in. So you could take, at that point, the one the patient's been wearing, you could just take an impression, picking up the transition line, capture how the tissues have healed, maybe take an impression on the integral side as well. There's a whole other series we have that explains all that. We're not covering it in this presentation. You take a new bite, a new opposing, send that off to the lab. Then your next appointment, second restorative appointment, would be Try-in, usually we're doing printed try-ins now because a patient could leave with that and wear that as a trial run, if you would, so to speak. And then the third appointment would be deliver a prosthesis. Some skip the try-in. We don't recommend you do that, but you could do it in 2 appointments to get to a final. So now we're going to talk about the precision IOS technology. So again, I've kind of mentioned this already, that this is a scanning method to accurately capture the position, the multi-unit abutments with that intraoral scanner. And then those scans are also going to capture, then you're going to get the opposing dentition, the bite, the working arch mucosa. So that's your impression. So you're getting all the data that you're needing. If you're working with NDX, the terminology you may be hearing or reading in some of our literature is going to be simply iOS. It's a trademark. Oh, sorry there, Jessica. I missed my TM on the simply iOS there. Oh, there it is down here. It's supposed to be up there. So that's a terminology phrase we have for doing what I'm about to show you is simply iOS. So let's get into that portion of it. So this is your phase 2. This is implants have integrated. Time has passed. You're ready to go to the final. So we like to recommend that you do a try-in with a resin prototype try-in. So to do that on your first restorative appointment, we're going to want you to provide us with some photos. We like to see, it's kind of like your initially photos that we like to see, but we want to see that with the provisional. We want to see the high lip line. Really important, those high smile lines are important. Some profiles, retracted front and left. That gives the lab just more reference points, and any other photos that you want to share with us, we love to have that as well. So that's one thing you're going to do in that first appointment. You're going to take your photos, and then for scans, you're going to scan the provisional, the existing provisional in the mouth. So patient comes in, they sit down, snap your photos, then you're going to do the scan before you remove anything, scan the provisional in the mouth. This is a good time too to look if you don't like where the screw access holes were coming out, that maybe it's coming out too far to the buccal, too far palatally. This would be a time to take into consideration, do you want to change out that multi-unit abutment to put an angled in and bring the alignment or the screw access hole within the alignment of the prosthesis better? Again, this is something you can talk about with your laboratory. This shouldn't be a surprise to you, restorative doctors, that you should have seen this. You should have seen the patient shortly after the surgery to make any final occlusal adjustments. So you should be aware of this, but just know that this is the time that you'd want to change things, is when you're going to want to do that. So then the other thing we want to do is we want to scan the opposing arch again. Always have to scan the opposing arch. It may have changed from the day of surgery. We're going to scan the bite. Okay. Just a little side note there. Sometimes to get these scans, we need to put it into denture mode or turn off the AI feature. It just kind of depends on your scanning unit. Your best friends are your implant reps, your laboratory, and your reps from your scanning manufacturers. So then we want to scan with the multi-unit abutments exposed. So basically the provisional's off. Scan that. We have beautiful healed tissues here. We want to have you scan that, and then scan the bridge, the provisional, out of the mouth. Some companies with their scanners, their scan bodies, the precision scanning system may have some scanning caps that snap in. Different things with different companies. But you want to scan that provisional 360 scan of that, send that to the laboratory. So then now for the again for the resin prototype try-in, or this could be, maybe you're not going to do a try-in. You want to go to the final. Here's your scan bodies for doing that. Again, we saw these earlier, but they're used now on the restorative step. So what was used on the day of surgery, the system that was used, and that protocol is similar, except now we have the tissues are all sutured and healed. So I just have the top that's kind of showing you the truss system. Again, it's just the same concept, just different things that you're trying to scan. They loop theirs together. You here's the optisplint. They have hexagonal mesh work that you'll loop to the scan bodies. And then there's more steps to some of these that I'm showing, but I just want to give you an idea that, there's different options for you. They're good options. Just find something that you're comfortable with. Then you can export all this information from your first appointment to the laboratory. Then the laboratory is going to go ahead and they will fabricate. Oh, yeah, don't forget the prescription. That's always important to have, is the prescription filled out. Note any changes, again, photos and etc. So now for the try-in, so let's say you did go with the resin try-in. So what you're going to do with that, now we're at our second appointment. Now what you're going to do is you're going to remove the provisional. You're going to seat the resin prototype. If you're not familiar with the Sheffield screw test, just Google that. It's a great way to figure out if you have a pass the fit or not. I'm not going to cover that in this presentation. We definitely don't have time for it, but look that up, the Sheffield test. When you get in these cases like this, it's a great way to verify a pass the fit. Then you place the remaining screws, make any occlusal adjustments. The patient could go ahead and wear that kind of for a trial, if you'd like. So you scan the bite. So it's kind of like your other appointment, but it's of the prototype. And if the tissue adaptation isn't correct, or you want it modified, you'd be taking an impression, either scanning or a physical impression. But the test drive is what this patient could leave with this prototype, this resin prototype, and wear it for a week to 2 weeks maximum to make sure that they're happy. It'll be white, really bright white teeth, and then stain pink typically is what we do anyways. But it's just really to make sure the occlusion's right, they're happy, the speech is good, etc. before you go to the final. So then you would either let the patient leave with that or remove that and return that to the lab. Don't forget to send any screws back to the laboratory. And we're in the home stretch. So now you've approved the prototype, and the laboratory now has fabricated your final prosthesis, whether it's a zirconia, nanoceramic, or a screw-retained denture tooth with acrylic and titanium, or printed denture with titanium. So quite a few options for you nowadays. So this is your third restorative appointment. You're delivering the final, and here you are. You're going to remove the provisional and seat the final. Once again, utilizing the Sheffield test. Very importantly is to have the patient allow time with your hygienist after your delivery appointment. The reason for that is you're going to find that many times, and almost always, because they've been wearing a provisional that was made when tissues were still, bone was going through some remodeling process, tissues were remodeling. Let's say that there's going to be a different way the patient's going to be able to get a floss threader through for their home care. They might need to be taught differently of how they're going to do that, especially patients who maybe are arthritic, maybe poor vision. You may have to come up with a different protocol for them to be able to do their home care. Because bottom line, home care is extremely important for your patients, because you do a great job, whether it's you doing the surgery and restorative, or surgeons, you're working with your restorative base. You all did a great job, deliver it, patients excited. And, a year, 2, 3 years later, they don't do their job and they don't see anyone anymore. And they come to you when things are in pieces, and they expect to pay how much for those repairs? Nothing. So anyways, important to do that. So that's what I've got for y'all. This is just wanted to throw out. This is something that I've used for some of my sources and some of the claims that I've made. Take care. Enjoy the rest of your summer. Thank you.